Well, thank you all so very much for joining us this evening. I want to welcome you to this expert education presentation coming from the Sash Bear Foundation. I'm Doreen Heineman, and I am the program manager here at Sash Bear. The Sash Bear Foundation is a Canadian charity. We are recognized nationally and internationally as a leading voice for families who are impacted by emotion dysregulation, suicidality, and related mental health challenges. Part of what we do is providing family connections throughout Canada, and of course, these expert education series presentations as well, and other programming to help provide skills and hope for families. Now, as I mentioned, we are a registered charity, and so I want to welcome you to make a donation to support our work at any time. I'm joined tonight by Lynn Coury, who is the co-founder and the president of the Sash Bear Foundation. Thank you, Lynn, for being with us. I'm also joined by two volunteers who work with us on a regular basis, Barb and Trisha, and they will be helping me monitor the chat behind the scenes. So you're welcome to put questions into the chat and the Q&A, and we will do our best to address those questions. We will have a few moments at the end, a few minutes for some questions to be answered by our presenters. But I do want to let you know that we have a large audience of a few hundred people, and so we won't be able to answer every question that comes in. And I would like to introduce our special guest presenters for this evening. So first we have Brandon Unruh, MD. He is an instructor in psychiatry at Harvard Medical School, and he is also the medical director of the Gunderson residence of McLean Hospital, which is a specialized residential program for individuals with severe personality disorders. He is also the founding director of McLean Hospital's outpatient Mentalization-Based Treatment Clinic, the MBT Clinic for personality disorders. His clinical approach is anchored in the integration of evidence-based treatments for personality disorder, such as dialectical behavior therapy, or DBT, mentalization-based treatment, or MBT, transference-focused psychotherapy, TFP, and general psychiatric management, GPM. He's an MBT trainer and supervisor through the Anna Freud Center in London, and he's one of the original cohort of GPM trainers established by John Gunderson. He has published on a variety of topics, including suicide, personality disorders, medical ethics, general hospital psychiatry, and literature and medicine. His academic interests also include the treatment of pathological narcissism and narcissistic personality disorder, and the intersection of psychological issues with spirituality and religiosity in both pathological and healthy forms. And our second presenter is Robert Drozek, LICSW, which is a licensed clinical social worker, and he is a staff psychotherapist in the Personality Disorders Service and Division of Alcohol, Drugs, and Addiction, also at McLean Hospital. He serves as a supervisor in the MBT clinic at McLean, a teaching associate in the Department of Psychiatry at Harvard Medical School, and also an MBT trainer and supervisor through the Anna Freud Center. And his publications examine the interface between psychotherapy and ethics, with an emphasis on the role of ethics in the patient's therapeutic change. And both Brandon and Robert are co-authors of a published book called Mentalization-Based Treatment for Pathological Narcissism, a Practical Guide, which was published by Oxford University Press. So without any further verbiage from me, I would like to welcome our presenters this evening.
Well, thank you very much, Doreen and Lynn and Jillian Galen, if you're out there, our local partner in BPD treatment at our home base of McLean Hospital here outside of Boston, for inviting us and for organizing us to be with you this evening. And we just want to begin by saying that we're really humbled and excited to be here and have your attention for an hour, because we're really inspired by your organization's passionate advocacy and dedication to fighting the good fight on behalf of and alongside individuals and families impacted by BPD. So Bob Drozek is going to actually begin the presentation. He's my dear friend and closest colleague who runs the MBT clinic with me at McLean and is the lead architect of this treatment approach that we've developed along with Anthony Bateman. Bob, over to you.
Thanks, Brandon. And yeah, thank you everybody for having us. It's great to be here. And let me share my slide. Okay, so the title, yeah, we're going to be talking about mentalization and pathological narcissism today. Just to kind of go over in big picture terms what we're going to be discussing, we're going to introduce the construct of pathological narcissism and narcissistic personality disorder, try to get our hands around what that is. We're going to overview mentalization and mentalization-based treatment, and then we're going to talk about like the rationale and some of the therapeutic strategies of MBT for narcissism, which is what Brandon and I work on together. So starting with narcissistic personality disorder and pathological narcissism, just give some kind of basic ideas about the illness. NPD has a lifetime prevalence of 6.2%, more elevated in men. 7.7% of men have NPD compared to 4.8% of women. And among psychiatric outpatients, those rates shoot up even higher, as high as 17%. And notably, NPD is heritable, with twin studies indicating 71 to 79% heritability for NPD. Also, lots of research on that parents with narcissism, given sort of different parenting styles, are more likely to have, or kids with narcissism are more likely to have parents with NPD as well. Narcissistic traits associated with a range of psychosocial challenges, emotional instability, substance use disorder, vocational impairment, violence, aggression, corruption, lethality from suicide, and dysfunction and distress in interpersonal relationships. One of the challenging things about narcissism is there are multiple ways to define the construct, which do have important implications for how we go about helping these folks. So the most kind of widely known and understood model is what we call the categorical model of NPD and the DSM. There it's defined as a pattern of grandiosity, need for admiration, and lack of empathy. And there's at least 5 of these criteria, which could be grandiosity, preoccupation with success, power, belief in one's own specialness and uniqueness, need for admiration, challenges with entitlement, interpersonal exploitation, lack of empathy, difficulties with envy, and arrogance and haughtiness. This is an approach. It's been it's been present in the DSM for a while. It's also been widely criticized for encompassing what we call like the grandiose presentation of narcissism, and the limitation is it can leave out other subtypes in presentations. So this sort of brings us to probably one of the most crucial distinctions in narcissism between grandiose versus vulnerable types of narcissism. So there's lots of research now at this point. It's widely accepted within the field that we have at least 2 different subtypes of narcissism. And the Pathological Narcissism Inventory is a self-report measure which can distinguish relative levels of vulnerable versus grandiose symptoms. So vulnerable narcissism is really dysregulation in emotions and self-esteem in response to essentially challenges, self-enhancing, or essentially like elevating or regulating self-esteem. So there's a bunch to it, but there's a sense of self that's very dependent on external sources of recognition and achievement. Hiding the self, there can be an avoidance of vulnerability, dependency, maybe showing one's own imperfections in relationships. There can be indifference to others who don't provide admiration to the person, shame around wanting that recognition, and also entitlement rage, when the person get very, very angry when others fail their expectations. Grandiose narcissism is sort of, again, kind of very similar to what we talked about with the DSM-5 categorical model. There's grandiosity, exploitativeness, and helping others to bolster self-esteem. So Both subtypes kind of share challenges with self-importance or self-centeredness, also kind of discusses entitlement. So that kind of joins the two different subtypes of narcissism. So, but recognition of these subtypes has really led to reconceptualization of narcissism and a way of framing it in the alternative model in the DSM-5 TR that can really encompass both types of narcissism. So it's more dimensional. It's not like, you know, does the person have this or do they not? We can think about it at sort of moderate to sort of severe levels of impairment. There can be different traits. So, you know, folks will have like a need, you know, a grandiosity, so a need to kind of pursue greater ideals or seeing themselves as already meeting those ideals and seeking of attention. But there's actually quite a bit of diversity. There are challenges in identity, which is basing self-esteem on other people, exaggerated or deflated self-appraisals, and then emotions can actually fluctuate based on how the person's feeling about themselves. Self-direction, the person can want to gain approval from other people quite a bit, have really high standards or too low standards actually. Challenges with empathy, and then also challenges in relationships, like using others to regulate self-esteem. So, you know, since this is a group, you know, where, you know, many folks here have family members with borderline personality disorder, we wanted to look at sort of how these can be connected. How can narcissism be connected to BPD? So research actually suggests there's significant symptomatic overlap between vulnerable NPD and BPD. And that's really important. There's one study, a really important study, showing that there's actually 90% symptomatic overlap between the two illnesses. So like BPD, vulnerable NPD is associated with depression, anxiety, and emotional dysregulation. Actually, there's in that same study that I mentioned shows that BPD is actually closer to vulnerable NPD than vulnerable NPD is to grandiose NPD in terms of the convergence of symptoms. So, in terms of, there's a recent literature review showing that compared to people with just BPD, people with symptoms of both BPD and vulnerable narcissism, they actually have decreased psychiatric complications, self-harm, or suicide attempts, less likely to be hospitalized in psychiatric facilities, and have fewer psychiatric comorbidities, and actually are more likely to exhibit traits of other personality disorders. So actually, interestingly, it's an interesting kind of takeaway. The authors of this literature review suggest that actually narcissistic traits can be seen as something of a protective factor for people with BPD, suggesting a better prognosis. That's provisional, but they feel like these sort of findings from these different studies support this idea. So we would sort of say, anecdotally, we'd offer just a handful of takeaways about BPD and its relationship to narcissism. So essentially, when we're sort of meeting new folks who seem to have, you know, traits of BPD, traits of narcissism, we really include narcissism in our differential diagnosis whenever we see functional impairments related to challenges regulating self-esteem. So if there's real challenges in terms of, like, you know, especially basing self-esteem on external things, we're going to start to think about, okay, are there elevated narcissistic traits here? So we're, you know, this is sort of like a, I don't know, like probably an overly simplistic heuristic, but we might say that BPD traits are triggered, or sort of symptoms are triggered primarily from loss of connectedness with others. So there's a inherently external orientation to BPD, that how connected I feel to you affects my level of stability and self. NPD has something a little more of an internal focus in a way. It's like, what are my own standards for self-worth? And then the person can experience instability when they're not meeting their own standards. Now, it's relevant to note, this is not a binary. Like, folks, not like, oh, is it BPD or NPD? We have many of our patients meet diagnostic criteria for both sort of forms of illness. So for patients with both, interestingly, improvements in BPD often reveal narcissistic traits that were previously masked and less prominent. So you'll have lots of patients who, um, were drawn to illness kind of in a more regressed state for much of, for a like more extended period of time. We get them into a good evidence-based treatment for BPD, and then we start to see sort of, some level of kind of entitlement or arrogance or devaluation of others that wasn't as prominent when the aggression was directed more towards self. So we absolutely see this, that it's really more of a kind of a dynamic situation where traits of narcissism can sometimes be elevated as sort of BPD symptoms get better. And then we've got to target that in the treatment. So yeah, people have probably heard of the unofficial quiet subtype of BPD, where patients can have self-directed aggression and avoidant tendencies. We'd sort of suggest that, for some of these patients, they could actually sort of, this subtype, which isn't official, could be explained by BPD plus narcissistic traits. And that's consistent with research showing that narcissism is linked with both anxious and avoidant attachment styles. So in terms of just some background about us and how we kind of came to this sort of approach, Brandon and I, as it's been mentioned, we're both staff in the MBT clinic. It's the only insurance-based adherent MBT clinic in the United States. Brandon did found the MBT clinic with the developers of MBT. And we started noticing that we were treating a group of patients. We started to kind of see that we're slightly different than sort of more kind of standard or traditional kind of patients with BPD. Often they had periods of success, periods of stability, high functionality, and then they would experience some significant life disruption, challenges at work, disruptions in relationships, shifts in financial status, which then precipitated these difficulties with depression, anxiety, and suicidality. And they would often, I think, because we were pretty attentive to the diagnosis of BPD here at McLean, they would be kind of referred to us for treatment of BPD. But we started to notice there was something different about these patients. They could often be more self-reliant. They could be quite selective about who they wanted to kind of engage with. They could sometimes struggle more with avoidance rather than the attachment seeking that we would see with traditional BPD. There could be a tendency to stay away from other people, actually. They crave connectedness, but they often did that indirectly by performing well, being the star patient in therapy, showing what they knew, rather than just kind of connecting in a more direct way. They could be intellectualized, find it challenging to access their emotions until they were upset, and then they could really plunge into the emotion. And there could be kind of challenges of defensiveness, being argumentative, often coming across as superior. And they could struggle with empathic deficits as well, especially when they were feeling threatened by others. So luckily, this was a time where there was tons of research, being done on vulnerable narcissism, and started to be like, this seems to fit a little more than just sort of straightforward BPD. And that's really led us to kind of develop these principles, because there's a way in which some of the empirically based principles of MBT, we found some modification when we're working with folks who have challenges regulating self-esteem. And so we developed the MBT for Narcissism group, which is a MBT group where all the folks have narcissistic personality disorder. They're coming there specifically for treatment of that. We published a 2020 paper and a book that was mentioned, that where we kind of spell out what are these principles, what did we found most helpful in helping folks with narcissism. So this is the book. It literally did just come out yesterday in the United States. I think it's been out internationally since September, but relate to the game. So Anthony Bateman, he's one of the developers of MBT. So he co-authored the book with us, which has been a real treat, and say best book on narcissism ever written. Obviously that's not true, but when you're writing and teaching about narcissism, you gotta take the opportunity to poke fun at yourself sometimes. And you sold some copies so far. So I'm just going to give an introduction now to MBT and sort of what is mentalization actually? What are we talking about here? So simply defined, it's the ability to read, access, and reflect on mental states in ourselves as well as other people. It's an imaginative capacity. Imaginative because we can't see mental states. We can't actually see sadness. We can't see insecurity, but we do consider what can be seen, and we make presumptions about what's going on in others' mind, and we can introspect and do similar things with ourselves. So mental states, thoughts, beliefs, emotions, desires, and it's focused on self as well as other to a greater or lesser degree at any given moment. And also it's something that we can kind of intentionally do. We can slow down and it's actually a little hard for me. I'm not getting to see all these faces of the people watching. So like, how can I mentalize the audience? What are they thinking of it? What we're presenting, right? That if I were to be looking and trying to kind of understand that would be more deliberate mentalizing versus reflexive, where we just are interacting with somebody and naturally we're making assumptions about what's going on inside them. So more experienced near definitions are attending to mental states, holding mind in mind, to make mental to mental eyes, kind of like the verb form of it, thinking about thinking, understanding, misunderstanding. And this is one that patients really like often, seeing others from the inside and oneself from the outside. So now, we've actually developed a conception of mentalization that really informs our treatment approach, where we kind of specify some domains of mentalizing. And really, it's it's a little technical, but it can be useful to think about it this way. Content, it's essentially three forms: content, context, and process. Content is the most basic form of mentalizing. We're trying to understand what we and others are thinking and feeling. So what. We also can think about why are we feeling that way? So not just, I'm feeling anxious right now. What's leading me to feel so anxious? Something to do with the presentation, maybe something else going on. And then process mentalizing is considering how we're relating to mental states in ourselves as well as other people. And this is, am I flexible? Am I tentative? Am I humble? Or am I more rigid, in my thinking, and sort of feel very confident that I'm right about something? Sometimes, mentalizing is always focused on psychological factors, but there are times when we're under stress, especially, patients with personality disorders can be less focused on the mental states, and they can be the visible, the actions that somebody's taking, how somebody looks. And then we can be more authentic and engaged when we're looking at mental states. We can empathically resonate with others, but there are also times where, there can be a disconnection that can happen too. So, and the key, one of the most important parts of mentalizing is this idea of curiosity. We have an interest in understanding what's going on with other people. So I'm going to turn it over to Brandon to take care of the second half.
All right. Thank you, Bob. All right. Hopefully everybody can see my screen. So we're aware that we're moving fast. We hope everybody's hanging in there with us. We're going to keep moving fast. That's because we want to end on time and make sure we save enough space for dessert, which is the question and answer is always the most enjoyable part for most people. So just a brief kind of detour into kind of the history books here, because as you know, in the story of DBT and Marsha Linehan, the story of how an evidence-based treatment for BPD develops tends to reveal something about the persona and the development and the values of its creator or creators. So just briefly, the current view of mentalization was first proposed in 1989 by Peter Fonagy, a Hungarian-born and British psychoanalyst and clinical psychologist. Here he is looking like he's actively mentalizing someone who's off screen here. And he collaborated and partnered with Anthony Bateman, a psychiatrist and another psychoanalyst from England, to develop and then empirically test and prove the efficacy for this treatment. Where Bateman and Fonagy were coming from was actually a place that was very parallel in one sense to where Marcia Linehan was coming from in observing that traditional cognitive behavioral therapy, or CBT, was not sufficient for treating a certain population. Similarly, Fonagy and Bateman were finding the limitations of traditional psychoanalytic treatment approaches in treating the same kind of population. They were also working in a particularly socioeconomically underprivileged and underserved social milieu, located in and around the Hallowig Day Hospital in an impoverished set of suburbs in London. And what they developed was initially an 18-month day hospital program in which patients were compared in two arms, one arm receiving treatment as usual. That arm showed minimal improvements over the course of the study, whereas patients receiving this new approach that was focused on enhancing and augmenting this mentalizing capacity that Bob described, that arm actually displayed significant reductions in really all the acute symptoms of BPD that we tend to care about, that we also see reduced in some of the DBT studies, such as self-injury, suicidality, inpatient hospitalizations, and depressive symptoms, as well as some interesting broader improvements in interpersonal functioning. These gains were maintained at 18 months, and in actually one of the longest follow-up studies that, to my knowledge, still has been done on any evidence-based treatment for BPD, actually that showed that those gains were actually relatively maintained 8 years after the conclusion of the treatment. That's pretty striking. These findings were then replicated in a more standard outpatient psychotherapy approach, combining individual therapy once a week plus a mentalizing group therapy session once a week, and found to, again, produce similar reductions in the acute BPD symptoms. These findings were then operationalized into a method of disseminating this treatment to clinicians and patients around the world through the Worldwide Training Center at the Anna Freud Center, where both Bateman and Fonagy are highly affiliated. And then it sort of came to America in collaboration with John Gunderson, one of our principal mentors, my old boss, before he passed a few years ago, who really was responsible, as many of you will know, for researching and developing BPD treatments at McLean Hospital and beyond. And John Gunderson, who was supervising me at the time, and essentially I found myself with this incredible opportunity to have the support of Bateman and Fonagy in developing this first clinic. And it wasn't long after that when Bob came along and really added so much to what we were able to offer in this new program. So we did set out, as Bob said, with the mission of being actually as adherent as possible to the empirically validated model, but adapting that for a North American hospital setting. We now, as well as others, in collaboration with Lois Choi Kane, are part of the team of people that are treating patients with MBT, and then trying to actually train and disseminate this approach to clinicians through the Gunderson Personality Disorders Institute, developed by Lois at McLean in partnership with the Anna Freud Center. So that's a little bit about sort of the equivalent to behavioral tech that exists for MBT. So what we now know is that MBT is a first-line treatment for people with BPD, with emerging evidence that supports its efficacy for antisocial personality disorder, which is, again, quite striking. Not a lot of evidence-based treatment for that population, and also for adolescents with self-injurious behavior. More broadly, mentalization has been applied to address psychological difficulties outside of personality disorders, including depression, trauma, spectrum disorders, substance use disorders, eating disorders, mothers with addiction, psychotic disorders, and so on and so on. Very parallel to how DBT ingredients have been extended and applied to conditions beyond borderline personality disorder. Interestingly, MBT is also increasingly being used to address more widespread social and cultural problems, such as law enforcement violence, children in foster care, parents undergoing divorce, school bullying, and school violence. And there are empirical findings supporting the application of mentalizing principles and interventions in all of these interesting contexts, including family members of people with BPD. And I saw in the chat, people were asking about, is there anything like family connections? So it turns out that there is. Not too long ago in 2019, a study came out showing some efficacy for what's called the MBT FACTS program, a mentalization-based intervention for families or partners living with or supporting a person with BPD. This will be of interest to all of you at SoshBear. Family members were involved in helping to write the manual and to deliver the intervention. Again, much like Family Connections from a DBT perspective. And the program covers topics related to mentalizing, many of which Bob described, and role-playing, mentalizing stance, and interactions with family members that support the mentalizing of family members to then in turn support and stabilize the mentalizing of their loved ones. So this randomized controlled trial basically showed that those families who received the MBT FACTS intervention right away, as opposed to those who were placed on a wait list, actually were associated with improvements in the degree of conflict between those family members and the loved one with BPD. So there were decreased reports by family members of the loved one's self-harm and suicidal threats, physical fights, arguments, emotional outbursts, and avoidance and withdrawal from the attachment with family members. So again, overall, less conflict, reduction in the chaos that family members tend to care about, which many of you will know firsthand. So the takeaway was this decrease in adverse incidents between family members and people with BPD. So let's now kind of take a step back, and we want to pull the curtain back just a little bit, because I saw people asking, is there a treatment for these problems? So we're just going to give you a very, very brief sense that about how this treatment approaches and targets these particular problems. So people were asking, is there a treatment that's available? And at present, the reality is there are no evidence-based therapies for these narcissistic difficulties. What exists is some rich anecdotal clinical literature coming largely from a psychoanalytic, psychodynamic perspective, case reports, case studies that suggest some of the principles that we've developed into the manual. There are theoretical adaptations from a DBT perspective and other therapeutic perspectives, but there's nothing that's really been systematized, and certainly nothing that's been evidence-based. The closest we have is the transference-focused psychotherapy approach, which is a theoretically systematized set of strategies, but again, which is not yet evidence-based. So that was the sort of no man's land zone in which we kind of found ourselves encountering these patients more and more. And we thought that since there's research that suggests MBT is definitely effective at treating both borderline and antisocial personality disorders, we thought MBT is a good candidate since it's effective for these near neighbor diagnoses. What about trying it for narcissistic problems, especially given the symptomatic overlap that Bob described between borderline personality problems and vulnerable NPD? And then when we look at the mentalizing challenges in antisocial personality disorder, we see some overlapping difficulties that we see in narcissistically organized individuals. We also have some empirical evidence that showed that MBT was especially helpful in comparison with treatment as usual. It was particularly impactful for patients whose BPD was embedded alongside other personality disorders, including narcissistic personality disorder. So where there seemed to be both borderline and narcissistic features, looks like MBT might especially have efficacy. The research on pathological narcissism shows that there are real difficulties with mentalizing. problems with empathy, as Bob described, this difficulty in taking other people's perspectives and recognizing emotions accurately in others, what's called alexithymia, the difficulty identifying and describing emotions within oneself. And then there's what's called constrained access to their own subjective states, especially those involving vulnerable emotions, such as sadness, shame, insecurity, feeling dependent or longing to be dependent on others in a healthy way. These inner states are particularly difficult for people with narcissistic problems to access and express and manage within themselves. Additionally, there's what we call the distinction between recognizing one's intent versus recognizing one's impact on others. This is a particular difficulty in NPD, even more so than in BPD, we would argue. Patients with narcissistic difficulties tend to overestimate their abilities to understand the minds of others, when it turns out, in fact, actually, they tend to be more severely impaired in precisely this area. We also think that the difficulties around mobilizing generosity are actually mediated by this mentalizing impairment with perspective taking. And all of this suggests that inhibited mentalizing, problems in mentalizing, may explain a lot of the symptoms that we see on the surface for narcissistically organized individuals. Furthermore, there are studies that suggest that mentalizing impairments are part of the pathway for developing narcissistic pathology. And then we have some studies actually from the TFP group in New York that show that improving and targeting reflective functioning and this perspective taking of mentalizing, that these are crucial mechanisms of change across the board for personality disorders. And their sample included people who had both BPD and NPD. So all of this, putting it together, including this last recent study that suggests that actually treatment outcomes for people with narcissism were mediated by improving this capacity to mentalize. Putting all of this together for Bob and myself, we thought, let's develop an approach that's systematized for targeting mentalizing in people with pathological narcissism. So you've heard Bob talk about this, this core kind of clinical pearl, as we would say, that we understand these problems to arise in attachment situations which stimulate or threaten a person's need for self-esteem or self-worth, or how a person values or esteems or thinks about or views themselves. And in response to situations which threaten those needs or stimulate those needs, people with narcissistic problems fall into acute problems with mentalizing, and that tends to show up in these what we call downstream non-mentalizing modes. So these are the more severe forms of mentalizing difficulties, and we have fancy jargon in MBT for describing these. Just to give you a taste of that, psychic equivalence mode is essentially the problem of holding one's beliefs or experiences or perspectives or feelings, holding them with too much certainty or rigidity, such that I'm not questioning how I think about or feel towards someone or towards myself. It just is the way it is because I think it is or feel it is. And of course, this is a largely unconscious process. So in narcissism, we see this showing up in those grandiose beliefs in one's own superiority over others, or the tendency to idealize another person, to think this person is, I need to be affiliated with them because they're the greatest thing since sliced bread. The sense of self is different from, fundamentally other than other people, superior to, and that shows up in devaluing other people or other people groups. But underneath that, alongside that, we see this sense of self as bad, deeply flawed, failing to live up to one's expectations, categorically worthless. And that's a little different how these patients get there than BPD patients. We also see this second non-mentalizing mode. It's called teleological mode. And this is where I explore the world in an overly concrete way, or I see myself and others in an overly concrete fashion. So this shows up in, as Bob described, the need to have tangible, measurable, external sources of self-esteem, such as my performance and my grade point average, the number of acceptances that I get to graduate school, where I go to college or graduate school, the amount of wealth or possessions that I have, the appearance that I put up on Instagram, the number of likes or followers that I have. It's about performance and these tangible, measurable indicators of self-worth. That's teleological mode. And in that mode, patients tend to need to respond behaviorally. They have to do something at a concrete level, such as retaliate or pull themselves back from some situation in which those self-esteem needs are experienced in such a concrete fashion. And thirdly, and finally, we have what's called pretend mode, which is a bit of a misnomer because it's not really about pretending. It's being overly disconnected from parts of oneself, particularly one's own feelings, and disconnected from the minds of others, failing to empathize with others' experiences, failing to relate to emotions or mental states in other people. So we have this sort of overly complicated slide just showing that there is a treatment pathway here that we have developed and modeled on standard MBT, and it involves really many of the same elements as standard MBT. That I'll just highlight that we do present and discuss the diagnosis of narcissistic problems explicitly. We educate our patients about how this treatment works. We set a list of agreed upon goals. We develop a formulation of where do the problems in mentalizing show up in the real world for this person and how are we going to work on them in treatment, and then we begin. The aims are basically organized around stimulating and strengthening this capacity to reflect on mental states in oneself and others in a flexible and nuanced manner. We could summarize that by saying it's to reflect rather than to reflex. So just respond impulsively. We do highlight problem behaviors such as attention seeking, perfectionism, avoidance, antagonizing other people, getting overly defensive. And we organize that by looking for how our patients fall into these non-mentalizing modes. And we particularly try to look for these self-enhancement processes that Bob described, which actually initiate these problem behaviors from the inside. And the idea is that as patients become more aware of these patterns within themselves and actually, learn to do something different with them in the moment, within the context of an attachment with a caring and concerned and interested therapist, there's a greater sense of self-continuity and coherence that develops, and there's secondarily increasing behavioral stability, interpersonal and emotional stability. So just to sort of get us towards the end here, because I'm aware we're at our end point, we focus on mental states. We explicitly take a humble, not knowing stance. We embrace the ordinariness of making mistakes and being imperfect ourselves. We do not interpret. We avoid some classical psychoanalytic techniques, which have the effect of sort of suggesting we know more than we can know about what's going on for our patient. And we're overall striving to be very transparent about how our own minds are working and ordinary about our own imperfections and foibles as we conduct this treatment. We're very active, much like a good DBT therapist. We're very active. We don't sit back. We will ask exploratory questions, but we will be quite challenging. We will direct our patients' attention to exploring specific aspects of what they're bringing up that's important. We are not scared to interrupt our patients, and we structure the sessions highly from the top down so that we're actually directing our joint attention to the areas we think that are most important. We're always emphasizing the need to be interested in differences in perspectives between ourselves and our patients. And again, as I've said, we own our mistakes as human beings readily in this approach. I'm going to, for sake of time and leaving us with question and answers, I think I'm going to skip through some of this so that we just prioritize time for your questions. But you can get the book and read it if you really want to know what exactly are we doing in there. But hopefully this just gives you a picture that we do have a systematized structure that's to guide clinicians so they have some sense of what they're doing and where they're going in the course of this treatment. So I will end now with just highlighting, if my bullet points will come in here, some final takeaways for families. So in contrast to BPD problems, as Bob said, which we can understand as arising often from this loss of or threats to connectedness, we view narcissistic difficulties coming from challenges with regulating self-esteem. That becomes a different area of clinical focus than is often focused on in BPD treatment. Narcissistic problem behaviors tend to appear in response to these experiences, as Bob said, which threaten a person's need for self-esteem. And these difficulties can sort of simmer along in a treatment that looks like it's organized around BPD. These difficulties can be kind of under the surface, especially early on when BPD is most acute. So there can be a hidden roadblock for many of our patients who aren't getting better from treatments that we know are effective for BPD. This is something for clinicians and patients to consider in terms of whether this might have been missed, and it might be helpful to actually reorganize the focus of treatment to focus on these narcissistic problems. And we know from experience and from some evidence that that may help facilitate and accelerate recovery. Final slide here is just for family members to keep in mind. If you think you see some of these difficulties in your loved one, remember that it's even harder for those with narcissistic vulnerabilities to accurately see and relate to the experiences of others, even harder than it is for those with BPD, and that they struggle more to consider the impact this has on people around them. And that, I think, even heightens the frustration for loved ones, even beyond that can be experienced around BPD. So when you're in an interaction with your loved one, when you see some of those self-enhancement behaviors that may be coming out in the interaction and you feel your own compassion to be fading, one thing we do as therapists, and you can do as family members, is to express interest in better understanding their experience. Ask them to slow down and actually really clarify. What are they thinking and feeling? How have they gotten there? Try to help them develop some more nuance and detail as they share that with you. And then listen for and validate where those challenges in maintaining a positive sense of self-worth may be underneath what they're saying on the surface. So we'll stop there. We've got 10 minutes for questions. I'm sure that will be inadequate, but as we're doing with our patients, we're trying to help them along in confronting and tolerating those inherent inadequacies and imperfections in life.
Well, thank you so much. I know there was a lot in there for all of us to unpack, and I've been going through the questions, and I know there will be more coming through. But first of all, thank you for that incredibly. I know probably not comprehensive to you, but to me felt very comprehensive overview of this approach. There were a few questions. I'm trying to group the types of questions that came in, and there are a few questions specifically about the relationship between BPD and narcissism within the family dynamic. So somebody's wondering whether there's any sort of genetic or familial pattern that shows up. Are there people, for example, that you typically see people with BPD and they more often have a parent with narcissism, or somebody with narcissism who typically has a parent with narcissism, or does it tend to fall within family patterns like that?
Yeah, it's a great question. And there's good research showing that there is a genetic component. So I think in the 70%. So that's heritable. So there are twin studies on it. There's also a good amount of research on I should say, what they call, quote, parenting styles that are sort of more associated with narcissism, and I should say that we're saying this to a group of sort of family members of people, so take this all for what it's worth. One problem with the research, I'll say in advance, is this is based on self-report by the person with narcissism. So that is a huge limitation. There's some stuff that's actually longitudinal, but most of it is by self-report and is not actually longitudinal in nature. But that said, it's this idea of parental overvaluation, which is sort of relating to the child as if they're really special, unique, different, kind of elevating them in a way. That's been shown to predict both grandiose and vulnerable narcissism. And there's another parenting style that has been shown to predict just vulnerable narcissism, which is you know, there's sort of different controlling tendencies that are in the dynamic. So it's not in any way to be blaming, but that is what the research says. And so that's what we know at this point. And there's one of the studies does show that parents with that among kids, and this literally was research on sort of, you know, younger folks with NPD, parents were more likely to have NPD. So that's what the research says at present, but it's still very provisional.
Great. Okay. Thank you. So, another question that came in, and sorry, I'm watching all these questions fly past me really quickly. So apologies if you did actually address this, but if you're raising children in a home where you know that there is someone who has these narcissistic challenges already, what can you do as a family member to help protect that child? Like what sort of protective factors could you bring in as another adult in the home?
I think we can both weigh in on this. This is probably really of interest to a lot of people. I mean, my own first response is keeping in mind this concept of we call teleological self-esteem. Just to remind you what we said about that, it's this sense of self and self-worth and value that becomes predicated in a narrow way on concrete infusions of, you know, achievement, things outside the self. How I look to other people, how many people are following me on Instagram, my grades, you know, in high school. If you sense that someone in your family that you love is struggling with that, the first thing to do is be aware that that is likely a deep internal struggle for them, actually. And actually try to help them get curious, as we do in very methodical ways in the treatment, but you can do and have even a greater impact on in the course of someone's development. Help them actually get curious about challenging that narrow perspective, that their worth is determined purely or primarily through their appearance, through their grades or achievements, whatever the external marker is that you see them starting to overly depend on. And of course, there's millions of ways parents have of doing that, but I think talking about that in an explicit way and marking and validating that actually you see that that's something that you wonder if that's something they're struggling with. And over time, you know, you might be able to help them listen to you as you model for them, you know, what it might look like to consider other ways of valuing the self that are less material. Bob, what are your thoughts on that?
I love that answer. And then I think that sort of gets at sort of how do we value our kids really, you know, just because that's such a lovely answer. Another way into it, which I think is very consistent with what Brandon's saying, is sort of focus. And what I was gathering from the questions, that there are people who are in family systems with people with narcissism, and there's concern about the impact of that on kids. In a real basic way, and we talk about this in the book, sort of folks with more narcissistic traits can really struggle mirroring emotions, you know? And so part of that, if you're in this sort of family system and you're sort of a co-parent with somebody with these sorts of challenges, the question is, I think there's a huge protective factor to be able to actually try to be attentive to the full range of your child's experiences. And because part of what we talk about in the book is that narcissistic sort of parents can really just represent back the good, right? Just this ideal image of the child. And this ability to actually reflect a full range of the child's emotions, sort of the more challenging feeling states, you know, the ones that may not fit our own ideals, that we would propose will be protective in terms of the development of narcissism.
Thank you. Thank you. A couple of questions that people have asked. Well, I think this is great. If in terms of families then who are dealing with someone who's an adult and these traits are, you know, fairly established in that person, you know, this is obviously really challenging for family members. So one person asked, is validation a helpful approach? Because this is something that families are suggested to do if the person has borderline personality disorder. But is that going to be helpful for someone who has these narcissistic challenges?
Well, we certainly think, and I want Bob to weigh in on this too, we certainly think in terms of crafting our treatment approach, that if anything, the efforts by the other to validate a person, to show that we are trying to do our best to understand what it's like for them, that actually, if anything, that may even be more important in the first place to sort of begin with somebody with narcissistic vulnerabilities. We find in treatment settings that we have to actually even draw that out, perhaps longer than we might have to do in the context of BPD, because it may take more of a sense of getting to the details and the nuance for a person with these vulnerabilities to really feel like you're listening, to really feel like you see the difficulty for them. It's just something we actually think we have to do more of, and we have sort of ideas in the book about how we slow it down. And we often have to start with helping the person describe the less emotionally charged elements of their experience. Just get the facts, as we say in our approach, and then from there, as they have a sense that you're listening to them kind of paint the picture of what was going on that was less emotionally charged, then maybe they're going to be in a better place to actually approach describing some of those more vulnerable emotions that Bob is saying tend to get under-mirrored and under-validated in that person's developmental experience. So overall, what I'm trying to say is there's a sort of greater care in scaffolding and working up to the validation. It may take longer and be kind of more painstaking, I think, in supporting a loved one. But Bob, what did you say about that?
Yeah, it's a great point. I would think like it's almost validation without agreement, you know? And that's sort of like there's a challenge with narcissism. It can become like something like it has its own gravitational pull, and you can be pulled in these dynamics to just kind of get absorbed by the other person's mind and preferences. So absolutely validate and don't let go of your own mind and your own boundaries. You know, and that's this idea that we have in MBT of contingency and markedness. So absolutely validate, but also there may be sort of lines you have to draw and actually say, well, this is where I'm at. And that's actually not going to be okay to me, you know, and to be able to kind of have the presence of mind yourself to make sure to draw that line so you're not really absorbed into the system fully.
So this clearly takes a lot of awareness and practice on the family member's part if we're to try and do this with someone. Okay. Yeah. I'm just imagining it myself and thinking that sounds like I would need a lot of patience and a lot of like my own emotion regulation to stay in that moment and slow it down and draw it out in the ways that you're describing. Okay.
And along those lines, I would say, because there's a lot of questions in the chat, like how do we get treatment for this stuff?
I was going to raise that next. Yeah.
Oh, you're right. Yeah.
Go ahead. You can jump right in there.
Well, I would just say a couple of things about it. Like in general, what we do is that sort of folks who are trained in the evidence-based therapies for BPD, like, you know, that's really what we're doing. We're really applying the therapies for BPD to narcissism. So that's sort of one, like go to where the evidence-based therapy is. One thing I would note, there's a lot of questions in the chat about MBT in Canada. I don't remember the name of it, Brandon, but Karen Enzing's group, what is it called?
I believe it's MBT Canada. There's a website, and yes.
Karen is she's really a world-renowned researcher in MBT. She's worked with Peter Fonagy. She's actually written some of the studies that we cited in our slides. She's an MBT trainer and really does a lot of work with kids. And she's also done research on narcissism and BPD and mentalizing. So I would say go to MBT Canada and sort of look more into it. But to your point, Doreen, I was going to also say, this is why family therapy can be so important, because it is really hard to manage all this. And sometimes we do, you know, if there's sort of families struggling with this, we'll kind of often send them to family therapists who do specialize in the treatment of narcissism as well, which we have those here. I don't know any in Canada per se, but you could sort of go where the evidence-based therapy is.
And when you are mentioning family therapy, is that specifically because it's more helpful to have the entire family involved and kind of on the same page? Or is this a way of kind of motivating and encouraging the person with narcissism to engage in treatment?
Well, Brandon, you do so much of that at the GR. Do you want to speak to that?
Well, yes, I saw in the chat, you know, well, what about if the person doesn't think they have this problem? I mean, so I think that's where, just like, you know, a lot of the advice in Family Connections and John Gunderson's BPD brief and other resources for families managing BPD within a family system, a lot of the advice is going to be the same as Bob's saying, kind of get clear about your own limits, but financially in supporting the person. Your own emotional burnout is an important thermometer to keep your own self-assessment, your wits about you around where you stand in terms of empathy fatigue. That's all the same, I think. But I think families can feel thwarted or defeated sometimes, or burned out in some special ways around somebody with more primary narcissistic problems. And, you know, again, what can be done, I think, as Bob's saying, is to actually enlist the help of a clinician who's familiar, particularly with NPD, to just first and foremost support the family in first forming a kind of more accurate understanding of what may be some of the sources of the primary narcissistic vulnerabilities the person may be having. I think that families, when they can be helped to understand these dynamics of self-esteem regulation, it does lead to some different approaches in supporting that person. Hard to summarize all here, but there's some tweaks, I think, that any clinician who's savvy about narcissistic problems can help families get to and support you in the troubleshooting, just as you would do in the case of BPD.
Thank you. I want to ask a couple questions. I know there's not a lot that's known about the natural trajectory of narcissistic personality disorder, but somebody asked, at what age do these traits initially show up? Is this something that you notice in children? Are children naturally narcissistic? You know, and then it's only become sort of pathological when they reach a certain age? Maybe you could speak to that a little bit.
Well, Bob was highlighting some of the developmental literature, which is very provisional, but you know, one of the places MBT came from is the literature and theory of attachment research. And one of the prototypical attachment styles that's known as avoidant or dismissive in nature actually can be observed very early on in examining interactions in a close manner between young children and their caregivers. And I think it's illustrative to, you know, we even will actually in some of our groups have patients view some of those videos and actually think back to their own early upbringing about what the experience was like for them in trying to relate to caregivers, but also trying to help them mentalize, imagine, connect to what might have been the experience on the other end for their caregiver. Because one of the interesting things we see in this attachment style, avoidant and dismissive attachment, which is heavily linked with adult narcissistic problems, is that, as Bob was explaining, the child actually does not tend to have vulnerable, distressing experiences validated or mirrored back to them in the caregiving environment. So what you actually end up seeing, even very early in some cases, is that actually that young child does not, they look like they're fine on the outside. They look like they're actually not so distressed. But if you put electrical skin conductance monitors on their skin, or you measure heart rate or blood pressure, you actually do see that there are objective markers of physiologic distress. There is internal dysregulation, but this child may already have learned that those distressing, vulnerable experiences really can't be expressed. You know, and that's not to say that the parent isn't well-meaning, isn't doing their best to try to reflect and look for those experiences and validate them. So we think there's something temperamental going on here. And then over time, of course, those temperamental vulnerabilities, you know, transact with, you know, the environmental response. So that is one thing that we see in terms of the early development of these interpersonal patterns, and even the sense of self. You know, we can infer something about how a person with this inner distress might come to regard themselves as just not having those kinds of vulnerabilities at all. I just don't have them because they've been kind of shaped through temperament and environment to actually present themselves to the world as though they live up to everybody's expectations or to their own expectations. So they can't bring those vulnerable expressions of self out into adult relationships. So hopefully that gives a little bit of a picture.
Yeah, and in support of that, You know, there's not, again, there's not tons of research on this issue of when do these traits start to show themselves. However, in this, you know, take this for what it's worth, but when you're doing interviews with people who end up having narcissistic personality disorder, by their self-report, these challenges were present from as they were sort of developing, right? This basing self-esteem on external things, feeling like any sign of vulnerability or imperfection evoked anxiety in them, right? Like they will tell you, yeah, that's sort of how I was in high school. Some challenges with dishonesty, you know, I gotta lie if it's going to make me look bad. So by self-report, patients will describe this being present, you know, quite a ways back actually.
And then in terms of family members who are looking at this from the outside and looking at the trajectory going forward, is there hope for them? Is NPD something that, you know, it can resolve naturally over time? Does it resolve with treatment? Does it resolve or improve if the family members, you know, are creating a different environment? What possibilities of outcomes are there?
Great question. I can start on this one. We know from some research, actually from John Gunderson and Elsa Ronningstam, who's perhaps the leading international expert on narcissistic problems, that they actually did in the late 80s into the 90s. We know that for people with narcissistic problems primarily, there is a more long-term course, and that course does seem to depend heavily on life events outside of treatment. You know, what's going on in the person's intimate relationships? What's going on in the professional setting? What's going on circumstantially, just in the scenarios that characterize that person's life? Major life events have a big impact on the course of improvement and recovery for somebody with narcissistic problems. We also know, though, that treatment can and tends to make a difference for most people with these problems. Actually, Elsa Ronningstam, again, in partnership with Igor Weinberg at McLean Hospital, just earlier this year published a case series trying to synthesize these case reports that actually Bob and I were both involved in writing one of these case studies. And they collected case studies from clinicians treating NPD and actually found that these treatments were associated with a kind of complex but definite trend of improvements in a variety of areas for each of those cases that was meticulously studied and written about. So that's not the same as evidence that would come from a randomized controlled trial, which we are partnering with other clinics around the country and outside the country in hopes of actually some of these studies being done eventually using this approach. But we have some initial preliminary evidence that treatment for NPD, when that is the focus, can help facilitate and expedite recovery. We know it can happen, but it's not the same message as there is with BPD. The natural history does not tend to fade over time in the same way that Mary Zanarini and John Gunderson's research has shown is the case for BPD.
Yeah, and I'll just put in the chat the article that Brandon mentioned, which is really
Great,
useful in terms of looking at like therapies for folks with narcissism across different modalities and looking at sort of what are kind of common ingredients in those therapies. And I would say, you know, another piece that's really important in terms of like we're treating lots of folks with narcissism in our private practices, in the clinic, and sort of the Gunderson programs. My experience is these patients do get better. And we're really seeing patients get better, which is why we like sort of wrote the book. I think one of the biggest thing that's really matters is so often a lot of folks with narcissism or traits of narcissism can be very bright. They can seem to have a lot of insight about themselves. They can sort of have a lot of ideas about themselves. And therapists can get so drawn into that narrative in a way that gets disconnected from the reality of how is that person actually living. And I would say one of the approaches that I think a lot of our programs at McLean are, you know, take really seriously is looking at the reality of the person's life and bringing that reality into the room. So it means being a little more challenging, actually. Like if we just explore feelings, most likely there's not going to be tons of change, but I would just say anecdotally, when you see therapists really bring in the reality of how the person is living, it's disruptive, but at the same time, patients tend to change. So that's our hope, is that by formalizing this model a little bit and, while still being very attuned to these patients, that we're going to be able to kind of help them move towards change.
Right. Thank you. Thank you so much. So it really sounds like, this is really we're at the beginning of a journey of understanding the trajectory and the treatment approaches and what's going to be effective. You spoke a little bit about borderline personality disorder and the comorbidity, and I think I'd like to end there because I know a lot of our audience, they're hanging in with us. They're really, really interested in this. But a lot of our audience, is dealing with BPD as well, or perhaps the comorbidity. And there are a couple of questions I think are so interesting. Could the traits of narcissism be considered in some way maybe maladaptive coping mechanisms for someone who has BPD, and maybe they're using the narcissistic traits to sort of help them manage the pain, the emotional pain of their BPD traits? Is that something you've come across, or?
Yeah. I definitely, I think that makes a lot of sense to me, and absolutely. And you really hear about these sort of folks, like, and they'll share about it being quite emotionally sensitive, quite vulnerable, but they find that they're bright and they can sort of get recognition from external sources, and they end up kind of having periods of actually doing extremely well, and it's sort of like, yeah, absolutely, sort of like the extrinsic self-esteem acts as a buffer for the identity diffusion of BPD. Absolutely. We see this all the time. Then the challenge ends up being, what happens when the sort of narcissistic kind of edifice begins to crumble? Then we can see the BPD regression. Brandon has a really great chapter in the book about a patient, I would say, that kind of falls into that sort of that category in a way. And so no, we see that all the time. And so that's why we see these oftentimes in dynamic relationship with each other rather than being a binary of either or.
So another question, which I think you've already answered, but I just want to articulate it to make sure that I am clear on it. You said that where you see this comorbidity, there's actually less, maybe less self-harm, fewer hospitalizations, that type of thing. And is that, in a sense, from what you've described, that the NPD traits are protective in a way for that person who has BPD, in terms of what their outcomes might be, as long as you said, the narcissistic edifice is still standing, and when it's challenged, then things can worsen dramatically.
I think you just stated it actually really nicely, Doreen. I'm not sure I would add too much to that. I think we've both had experiences where someone came to us with a diagnosis of BPD, or we even make that diagnosis ourselves at the outset of treatment, because there's this acuity of dysregulation that really is much more consistent with the kind of stably unstable kind of picture that really fits more for most people with BPD. But then as the acuity, kind of some of the fires get put out, as Bob described, you see this kind of reconsolidation around a more rigid self-structure, which is organized, as Bob said, actually rigidly. It's something to fall back on. It's protective, it's robust. Sometimes, though, we refer to that as a hologram self. It's not a full self. It doesn't actually buoy the person up from the inside in robust ways. It's a kind of facsimile or a facade at times. The person may have real competencies and skillfulness in a variety of areas, as we see in many people, as Bob described, with narcissistic problems, but it doesn't actually congeal in a multi-layered way. You see that underlying dysregulation in self-esteem. That vulnerable self is, in a way, sort of hiding out somewhere. And sometimes it takes a big fall from grace, or being toppled off of a pedestal, not getting into graduate school, not getting a coveted job position, being outdone by a rival in a professional setting, the collapse of a marriage, having a double life revealed in a public way. These massive blows to that self-structure, which has been presented to the world. This is me. I'm successful. I'm beautiful. I'm brilliant, whatever it is. When that collapses, then that person's whole self-structure crumbles, as Bob is describing. And sometimes it just takes a major insult or blow to that sort of hologram self for the narcissistic vulnerability to kind of be exposed. But we do see it more subtly sometimes in someone's interpersonal patterns. And that's what we tend to kind of try to look for as we're making these diagnoses, not just the big falls from grace that can plunge someone into suicidality, but the more subtle signs as well.
Wonderful. Thank you both so much for sharing so much of your wisdom and your expertise from all of the work that you've done. I know from the response we've gotten out there that it has been very, very much appreciated. So I just want to remind everybody out there that the Ashbear Foundation is a charity, and you can always make a donation to help us provide presentations like this to you and the other work that we do, Family Connections and other programs. Please contact us if you want to know more about the work that we do. And this presentation has been recorded so that people can watch it again on YouTube. I encourage you to subscribe to our YouTube channel so that you'll get a notification when we get the recording posted. And thank you so much again to our presenters, Brandon and Bob. Thank you so much for really sharing so much information about this really important topic.
Thank you very much to all of you, and best wishes to you all.
Nice
Good
to
night,
see
everyone.
everybody.